Speaking to a group of what we might call brand ambassador patients, patients that have been through extensive surgeries. And if you could give guidance on the one question that patients should ask, but in your consults, they rarely ask, what would that be?
Generally, I'd say they should ask two questions. One is, Doc, what's the worst case scenario? And, for me, that's always infection. That would be my reluctance to getting a joint replacement would be if I developed like a PGI. And I was at a conference recently, as I alluded to earlier, and he's a surgeon, and he said, Steve, the worst thing that ever happened was I got a PGI and I had to get a trochanteric osteotomy. And I go, how are you now? He goes, well, I'm good, but that really sucked. That would suck. I mean, there's some technology that's looking at biofilm eradication so that, yes, if you did get a PGI, then hopefully you wouldn't need an explant. But that would be the thing that scared me the most. So that's question number one, is like, what's the worst case scenario and infection? The second question I'd always, if I was the patient asking the surgeon, I go, how many have you done? And I hate that question because I get it. At a certain point, I had not done thousands of these yet. And I don't know what that answer is. People go, how many does it take you to be really good? And I don't have that answer because I think I'm still getting better. And I guess maybe as the surgeon, if he said a 10, I might have to question that. But a surgeon who knows exactly how many cases that he's done, and more importantly, one that knows his exact complication rate, means he's caring about what's happening and making process improvement to try and prevent stuff from happening.
Yeah, the challenge to the Malcolm Gladwell 10,000 hours, you guys are forced to learn it before 10,000 hours, because of the key stakes for sure. Here's my last question. You've spoken at meetings. Is there any current topic, position that is getting pushback right now? And if so, what does that resistance level say about where the field actually is?
I mean, I'd say there's kind of two camps. I mean, there's the hip camp, and historically in the past, the anti-hip approach was kind of poo-pooed, granted, because it was mostly a posterior-driven field, and my training was mostly in posterior approach, and oddly enough, now I hardly ever do a posterior approach. But at least now that's gaining traction at meetings where more and more people are wanting to discuss anterior approach, anterior revision, as opposed to just saying, let's go through the posterior aspect. From a knee standpoint, we've seen a huge drop-off in unis. And 10 years ago, it was, let's do a bunch of unis. And the unis, it's a great patient population.